Hi, everyone. My name is Dr. Michael Wald, and welcome to today's podcast entitled Inflammatory Bowel Disorder. You're listening to Ask the Blood Detective, and I am the original blood detective, Dr. Michael Wald. I practice in Chappaqua, which is located in Westchester, New York, which is about an hour north of New York City. To reach me with your comments about this show or any other shows that I've done, or to give me show ideas, please email me at info@blooddetective.com. You can call me at 914-552-1442, and you can visit the website and use the search bar on the homepage to access tons of free content on practically any topic that you can think of at drmichaelwald.com. That's drmichaelwald.com. Okay, let's get into inflammatory bowel disease, what I call the inflammatory bowel disaster. And the reason I call this podcast a disaster, well, there's a few reasons, actually. One is that most of the individuals that I've seen over my 30 plus years of clinical experience have visited gastroenterologists, or at least internists, but mostly gastroenterologists before they even see me, and they've been diagnosed with inflammatory bowel disease. They don't seem to have any idea of really what the condition even is, other than it involves inflammation in the colon. Most of the clients that I've sat down with also have never been given any sort of personalized nutritional guidance whatsoever. They haven't even seen a regular dietitian, although with all due respect to dietitians, and I am a licensed dietitian, we do not learn the alternative types of therapies. The nutritional information and education that dietitians get, in my approximation, is very much out of date. And if you doubt that, just think about hospital food. Everyone seems to know that hospital food is pathetically bad, and that these diets are determined by dietitians in a hospital-based setting. So what we're going to do today is cover several key components of inflammatory bowel disease, and my hope is that, and my intention is that, by the time you're done listening to the show, you will have a very strong base of understanding in what inflammatory bowel diseases are, and whether it's you or someone you know, or someone you love that is suffering from inflammatory bowel disease, you'll have many more options. You'll also be educated in not just the traditional medical treatments for inflammatory bowel disease, but many of the natural treatments. So what are we going to answer today? A couple of things. First, what is the definition of inflammatory bowel disease? We're going to talk about the common symptoms that many people experience with inflammatory bowel diseases. How is inflammatory bowel disease even diagnosed? What are its causes? Because causes are almost never looked at by gastroenterologists. And so many of my clients are very confused. They'll say to me, Dr. Wald, how is it that I'm visiting with a gastroenterologist, a specialist of the gut, and they do not know anything about nutrition? And what I say to them is, well, they know a little bit about nutrition. They know that gluten in celiac disease is bad, and that needs to be removed for life if you have gluten, celiac disease. And then, of course, there's gluten intolerance, which is not celiac disease, where you have to remove the gluten, you fix up the body's response to the gluten, and then that gluten probably can be reintroduced. So that's gluten intolerance, or gluten allergy, you might say. Although with allergies, that generally means, depending on the type of allergy test, that gluten may have to be eliminated as well for life. My point is, gastroenterologists are not trained in nutrition. They receive as much nutrition as the average physician, which is roughly 27 hours over the course of something like 5 to 7 years of medical education. So we're going to discuss the treatment options for inflammatory bowel. Is there a cure for inflammatory bowel disease? How does diet affect inflammatory bowel disease, if at all? What other complications can arise in those with inflammatory bowel disease? Is there a genetic predisposition? And how does the inflammatory component of inflammatory bowel disease affect a person's daily life? And once again, for all of you just joining us, my name is Dr. Michael Wald. I'm the Blood Detective, and today we're diving into the topic of inflammatory bowel disease and the various medical and nutritional treatments available. We'll be discussing things like the use of omega-3 fatty acids, medium-chain triglycerides, vitamin B12, iron supplementation, the potential role of turmeric and digestive enzymes, and a low dietary inflammatory approach to managing these inflammatory bowel conditions. So thank you so much for giving me some of your time today to explore together the latest research and practical strategies for addressing the inflammatory bowel diseases. So I suppose I'll start first by sort of a definition. So inflammatory bowel diseases are a group of chronic conditions that affect the gastrointestinal tract, and they're characterized by inflammation and damage to the gut lining. And the two main types of inflammatory bowel disease are Crohn's disease and ulcerative colitis. These different presentations are distinct in that, anatomically speaking and pathologically speaking, when a gastroenterologist biopsies the colon to try to distinguish what this inflammatory condition is, or whether or not it's Crohn's disease or ulcerative colitis, they find a different pattern of degeneration. I'm just going to give you one bit of detail about that, so you just have an idea that there does seem to be a difference in terms of the presentation between Crohn's disease and ulcerative colitis, but ultimately and fundamentally, they're thought to probably be the same condition in terms of mechanisms of causes. So imagine and picture in your mind the colon and the colonic wall with inflammation. In ulcerative colitis, the inflammation is kind of everywhere. And in Crohn's disease, you have inflammation, then you have normal intestinal lining, then you have inflammation, then normal intestinal lining, then inflammation, and it goes on and on. So you have areas, what they call skipped lesions. You have lesions of inflammation, then normal tissue, then more inflammation, then normal tissue. So that's called Crohn's disease skipped lesion presentation. And ulcerative colitis, as I mentioned, doesn't have the skipped lesions, it's just lesions, okay? Crohn's disease, let's start with that, can affect any part of the gastrointestinal tract. I mentioned the colon, but it can affect any part. So from the mouth to the anus, and cause symptoms such as abdominal pain, diarrhea, fatigue, and weight loss. Ulcerative colitis, on the other hand, primarily affects the colon and the rectum and causes symptoms such as abdominal pain, diarrhea, and blood in the stool. And these two conditions may present identically in terms of the signs and symptoms that arise in an individual. And interestingly, according to the Crohn's and Colitis Foundation of America, inflammatory bowel disease affects approximately 1.6 million people in the United States, and the prevalence of these conditions is increasing. Here are some of the prevalence rates for inflammatory bowel disease in the population. So as far as Crohn's disease, we'll start there first. So in the U.S., the prevalence of Crohn's disease is estimated to be around 200 to 300 cases per 100,000 people. In Europe, the prevalence of Crohn's disease is estimated to be around 100 to 200 cases per 100,000 people, so close. Now, ulcerative colitis in the U.S., the prevalence of UC, or ulcerative colitis, is estimated to be around 100 to 200 cases per 100,000. So that's identical to the prevalence of Crohn's disease in Europe. I should mention too, don't get too thrown about these percentages, because if you want to review them as well as any aspects of the notes for today's show, you need to just go to my website and look up the name of the podcast, or just type in inflammatory bowel disease or inflammatory bowel disease disaster, and you will find both audio and you'll find the detailed notes, which are generally several pages long. So we've been discussing ulcerative colitis. I just said that the prevalence of ulcerative colitis in the U.S. is about 100 to 200 cases per 1,000. In Europe, the prevalence of ulcerative colitis is estimated to be between 50 and 100 cases per 100,000 people. So it's important to note that these prevalence rates are based on reported cases, and they may not reflect the actual number of people living with these conditions, as some cases go undiagnosed or they're just misdiagnosed. Additionally, the prevalence of inflammatory bowel disease can vary depending on the population being studied and the criteria used to define the conditions. But if you have any semblance of inflammation in your bowel, that's all I need to know in terms of applying nutrition. So let's review some of the medical treatments for inflammatory bowel disease, because this particular show topic on inflammatory bowel disease, as well as every other show that I do, I always review the traditional medical treatments for the conditions because, first of all, knowing those other treatments can give alternative practitioners ideas about trying to use natural treatments that work similarly as traditional medical treatments. And you also want to know what the medical treatments are in addition to the nutritional treatments so that you're simply just well informed. There's somewhat of a bias in alternative healthcare where I'll have clients come to me and they are a no to anything medical. And I respect that. But many times when I discuss with them the medical ways of doing things, it gives me ideas about how to do things naturally, similarly. So what are the medical treatments for inflammatory bowel diseases? So inflammatory bowel diseases, or IBD, encompass a group of chronic inflammatory conditions of the GI tract, including Crohn's and ulcerative colitis. This much you know. The treatment of IBD aims to induce and maintain remission, alleviate symptoms, and improve the patient's quality of life. It's thought in medicine that there's no cure for these conditions. There's only mitigation, alleviation, maintaining remission. But I have had clients over the years that they're seemingly cured in that it's been decades since we began natural treatments and they seem fine. And prior to that, they had multiple hospital stays over the course of years. So there's several medical treatments available for IBD, and their success rates vary depending on the individual's condition and response to treatments. So there are aminosalicylates, such as mesalamine and sulfasalazine, and they're often used as first-line therapy in medicine for mild to moderate ulcerative colitis. First-line therapy means they are used first. I think that nutrition and natural treatments and improvements in lifestyle should be used first. And in many conditions, the first-line therapy is nutrition. At least it should be. Like gluten, like celiac disease, removing gluten, like diabetes, adjusting sugar intake in the diet, exercise, etc. So these particular drugs work by reducing inflammation in the lining of the intestines. And while they're effective for some patients in inducing and maintaining remission, their efficacy can vary and does vary widely among people. And I find that when clients come to me and they say, Dr. Wald, is there a way I can deal with this condition without medications? I give them the honest answer. I say, I don't know. We'll figure that out once we try, and we give it a shot. At the very minimum, I can tell you that the use of nutrition generally makes the traditional medical treatments a lot more tolerable. And there are nutritional consequences to inflammatory bowel disease, and they're almost never addressed by traditional gastroenterologists or internists or family practitioners. So it's up to practitioners similar to myself, which have extensive training in how to read laboratory work, how to order laboratory work, how to do physical exams. Dietitians, clinical nutritionists, and most naturopaths in most states cannot do laboratory work. They're not even allowed to order it, and there's a reason for that. They don't get any training. So it's important that if you choose a nutritionist to deal with a chronic condition like the inflammatory bowel diseases, you want to choose a practitioner who has a scope of practice which allows them to figure out your biochemical individuality based on labs and then apply personalized nutrition for your particular experience, you might say, of inflammatory bowel diseases. So what I'm trying to say here is that I could have 10 patients with inflammatory bowel disease diagnoses. They may even have the same diagnosis within that, meaning they're all Crohn's disease, let's say, or maybe they're ulcerative colitis. But their nutritional treatments are almost never the same because there's many, many differences among individuals that may experience inflammatory bowel diseases. So the other class of drugs, in addition to the aminosalicylates, are corticosteroids. So corticosteroids, which most of you probably know, such as prednisone, is a potent anti-inflammatory medication used to control moderate to severe IBD flare-ups. So the corticosteroids are generally not recommended for long-term use due to their potential side effects. So chronic use of prednisone can result in degenerative joint disease, ligament rupture, osteoporosis, reduction of immunity, The use of the drug chronically, corticosteroids, prednisone, can increase the risk of infections because, again, it lowers immunity. It increases the need for many, many nutrients. Almost none of these things that I'm mentioning are managed by traditional gastroenterologists at all. Let me just take a quick moment here to identify myself. For those who are just joining us, you're listening to Ask the Blood Detective. We're listening to a topic called Inflammatory Bowel Disease Disaster. You can reach me by calling 914-552-1442, and you can email me at info@blooddetective.com, and the website is drmichaelwald.com. And a little bit of a disclaimer. This information here is for your education. It is not to replace sound medical or health advice. And if you use or misuse this information, that is your responsibility. So be careful. You want to deal with inflammatory bowel diseases with trained nutritional professionals. Now, back to corticosteroids. They can be successful in rapidly reducing inflammation and providing symptom relief, but they're not a preferred long-term option. One of the other drawbacks of chronic use of prednisone is that it causes the adrenal glands, which are these tiny little glands about the size of your thumb that are on top of your kidneys. Think of your kidneys as your fist. If you curl your fist up, that's about the size of your kidney. And your thumb on top is about the size of the adrenals, and you've got two kidneys and two adrenal glands, and they're towards the back of you. So the success of medical treatments for IBS, I wanted to mention, that the corticosteroids can cause atrophy of these adrenals, which can reduce one's ability to manage stress. Everything from chronic hiccups to chronic insomnia can all be induced by use, even the proper use, of corticosteroids. So I was saying that the success of medical treatments for IBD vary widely among individuals due to factors such as disease severity, location within the gastrointestinal tract where the inflammation is, presence of complications, individual responses to medications, their nutritional status, any other comorbid conditions, certain medications, even certain supplements. All of these things can potentially change a person's experience of the inflammatory bowel diseases. And additionally, personalized treatment plans that consider all of these factors and the patient's overall health and their preferences and potential side effects, they all play a crucial role in achieving successful outcomes in inflammatory bowel diseases. So what you need to know in summary so far is that medical treatments for inflammatory bowel disease encompass a range of options aimed at controlling inflammation, reducing remission, improving a patient's quality of life. And the success of these treatments depends on various factors and often requires a personalized approach tailored to each individual's unique needs. And I keep saying this unique needs thing because there's a lot of lip service given to dealing with the individual and finding their unique needs and their need for a diet, let's say, nutritional supplements based on their personalized biochemical individuality when practitioners are not checking these things. So let's talk about the nutritional approaches to inflammatory bowel diseases. So inflammatory bowel diseases like Crohn's disease and ulcerative colitis or proctitis are characterized by chronic inflammation of the GI tract. This you know. Now, while nutrition alone may not officially be acknowledged as a cure for IBD, it does play a significant role in managing symptoms and supporting overall health. Several nutritional approaches have been explored in the medical and nutrition literature, and over the last several decades, applying them to individuals, I've come up with about a dozen or so fundamental nutritional considerations that might apply to most people with inflammatory bowel diseases, although they might not apply to you or anyone else you're thinking about that has this particular problem of inflammatory bowel disease. So now let's talk about some nutritional approaches and some dietary modifications and specific nutritional supplements that might be of help. I think the first is the dietary approach of a high-protein diet, because consuming adequate protein is important for individuals with IBD, and it supports tissue repair, helps maintain muscle mass or lean mass or organ mass, which can be compromised due to inflammation. Now, this is a big deal because, first of all, in chronic inflammatory diseases, the body in the affected person tends to steal protein from different areas of the body to try to repair the chronically inflamed gastrointestinal tract. So that means other parts of the body are going to become more and more deficient in protein. So muscles tend to atrophy, and organs are lean mass as well. So lean mass is muscles and organs, and they are atrophied. And as organs and lean mass are atrophied, that's usually associated with a worse course of disease, an increased risk of dying of anything, and increased risk of comorbid conditions and problems of quality of life. The amount of protein a person needs should be no less than 0.8 grams per kilogram of body mass, but it's best to have a test done called the body composition test. I've mentioned it during many of my shows. The reason I have is because the body composition test, also known as a bioimpedance analysis, is the only way to learn what the metabolic rate is of the body and the percentage of muscle, water, and fat. And there's many other parameters that are checked in the body that are very important. And the body composition or biomarker test or bioimpedance test is considered the number one biomarker test in human beings. What does that mean? Folks, this is big. No matter what health problem you have, no matter what solutions you choose, natural, nutritional, medical, it doesn't matter. For those to actually add up to anything, if there is improvement in symptoms, we must see an increase in the percentage of lean body mass. If someone feels good and there is no increase, or in fact, there may even be a decrease in lean body mass, they are not going to stay better. They're not going to remain asymptomatic or having less symptoms. The best outcomes are when there's an increase in lean body mass, and the amount of protein should be based on a careful examination of the patient, various lab tests, including but not limited to the body composition test. That's the number one fundamental thing, and the first meal of the day should be a high-protein meal. And you've all heard about the anti-inflammatory diet. So following an anti-inflammatory diet rich in fruits and vegetables, whole grains, lean proteins, and healthy fats may reduce inflammation in the body. So with every client that I'm with, I look at their normal diets through a 7 or 14-day food intake log, and then I look at the foods that are probably pro-inflammatory. There aren't really good tests to tell whether or not foods are inflammatory or not, and you can read books about which foods are inflammatory, let's say compared to others, but the fact is the following, and this is how blood detectives think. This is how you're smarter, you go another step in your thinking. Any food can be pro-inflammatory or anti-inflammatory depending on the person, how they digest and manage that food metabolically. So broccoli might be anti-inflammatory for one person, but pro-inflammatory for another. So a combination usually of elimination of certain suspected foods that I think are inflammatory and reintroduction can help clarify which foods may be more or less inflammatory for the person. And that same procedure of elimination, reintroduction, might also tell me whether or not a food is allergic. And regarding food allergies and intolerance, so an allergy means the immune system's involved. An intolerance means, by definition, the immune system is not involved. So maybe the person's intolerance to foods might have to do with, let's say, stomach acid levels that are too low and or low levels of enzymes in the small intestine. Okay, so low stomach acid or no stomach acid and lack of digestive enzymes which digest protein, carbohydrates, and fats in the small intestine, which are delivered by the pancreas, may be affected. So those are food intolerances. But if a person could develop food allergies because they have an immune issue, like I mentioned, by definition, food allergies mean that the immune system's involved. But often people will have food allergies along with all these inflammatory foods in their diet, and they might also have low stomach acid and or low digestive enzymes. So all of these factors need to be managed, because if you don't manage someone's digestion and absorption, all the nutrients I'm just about to talk about will be relatively useless. It absolutely shocks me. This is another respectful criticism I have for the gastroenterologists. Almost none of them check a person for malabsorption. They don't seem to do malabsorption tests. I don't know why. It used to be standard practice. I believe it's because they're more expensive tests that these gastroenterologists can do. And since they wouldn't change what they do if they had an absorption test, at least in their minds, because I asked a gastroenterologist once, why don't you do this? He said, well, it wouldn't change what I do. And of course, I could think of a dozen ways just right off the bat that knowing what a person's absorption or lack of absorption, how that would actually affect what you do. For example, if someone has malabsorption, okay, now I'm using the term malabsorption, that means the person would need to have enzymes. So that's the first, or the second nutrient, I should say, other than proteins, that needs to be managed. I like to have absorption tests done pre and post to make sure that the person's absorption is fixed. So I might need to give a person stomach enzymes, hydrochloric acid, and pepsin. And that needs to be done very carefully, and there's protocols for doing that. So I won't go through them here because I don't want you doing that on your own. And then there's the use of exogenous or supplementary pancreatic enzymes or plant enzymes. I like pancreatic enzymes because they're much more potent than plant-derived enzymes. Okay? Plant-derived enzymes are not as potent enzymatically as animal-derived enzymes, not even close. The same goes for, let's say, iron in plants like spinach. That iron is a different, not particularly absorbable form of iron compared to the iron in meat, which is much more absorbable. Now, I'm not making the argument that someone should be a meat eater, because meat also is high in arachidonic acid, which is probably one of the most, if not the most, inflammatory compound in our diets. But that doesn't mean that some people with inflammatory bowel diseases can't tolerate meat. You have to look at individuals. Sometimes you can give them enough enzymes where they can manage it. Enough of that. And then there's vitamin C, which is, as you know, an antioxidant that supports the immune system and may help reduce inflammation. And as I discuss these various nutrients, I might say reduction of inflammation and antioxidants several times with several different nutrients, but different nutrients don't always necessarily work on the same inflammatory pathways or the same antioxidant pathways. So you might be thinking, well, why do I need 3 things that are antioxidants and 3 things that are anti-inflammatory when I could just take one? Because you can't take one. You want to use nutrients in a synergistic way, which means in a combination in terms of doses and types of nutrients and sometimes timing of the day with foods, without foods, all of that so that we maximize their potential for healing. And those with inflammatory bowel diseases are usually under chronic stress. Vitamin C is needed to manage stress and to repair tissues. And then there's zinc. Adequate zinc intake is essential for wound healing and immune function and inflammation. And the changes occurring in the intestinal tracts of those with inflammatory bowel diseases, those are wounds. And then if you're going to take any medications like steroids, they tend to lower zinc. So zinc needs to be put back. The amount of zinc needs to be determined based on an individual. I usually perform zinc testing for that. And then there's vitamin D3. We know that there's a problem with many people with inflammatory bowel disease metabolizing vitamin D3 properly at the intestinal border. The same thing with folic acid. So vitamin D3 has been associated with reduced inflammation when used correctly and dosed appropriately for the person with inflammatory bowel disease. So dosing appropriately means how much does the person weigh, what percentage of them is lean body mass. I like to base my doses of nutrients on lean body mass. We want the vitamin D3 in the blood to be a level of a 70. Even though 30 is normal, it's too low. 31 is certainly too low. We want no less than a 50 on blood testing for D3, and we want about as high as a 70. Again, very, very important anti-inflammatory and immune modulating effects of vitamin D3 in inflammatory bowel disease. And then, of course, there's omega-3 fatty acids. Many decades of study on omega-3s in inflammatory bowel diseases. So we know omega-3s have anti-inflammatory properties, particularly benefiting those with inflammatory bowel diseases. Again, the amount of omega-3 will vary. I like to use liquid omega-3 oil, which has a higher concentration of EPA relative to the DHA portion of fish oil. So fish oil is EPA DHA, which some of you know. And for inflammatory bowel diseases, we want more of the DHA and less of the EPA. If someone had cardiovascular concerns, I'd probably have them on higher amounts of EPA and lesser amounts of DHA. There is testing for omega-3 fatty acids and their breakdown products, but I find them almost never needed. I first use my clinical judgment and some other indirect tests before I spend a client's hard-earned money, several $100s, on an omega-3 metabolite test that almost never changes what I do. And then there's the combination of turmeric and ginger. So these spices contain compounds with anti-inflammatory properties, and they've been studied for their potential benefits in managing IBS symptoms, or IBD symptoms, I should say. The amount of turmeric is probably needs to be in the 6 to 12,000 gram range, or milligram range, sorry. So about 6 to 10 grams, or 6 to 10,000 milligrams. And the amount of ginger is usually 2 to 400 milligrams relative to the turmeric. Turmeric has immune modulatory effects, tissue reparative effects, helps to thin the blood, improving circulation, and turmeric also needs to be combined with substances that allow it to be absorbed much better. So turmeric alone, or turmeric with ginger, is not as good as turmeric with a carrier. And then there are probiotics. Folks, probiotics are not all the same. Some probiotics are particularly good for anxiety. Other probiotics have been shown to be miraculous in helping those with depression. Still, yet other probiotics are good for the small intestine, others for the large intestine. So the combination of different types of healthy intestinal bugs or probiotics needs to be determined one person at a time, one situation at a time. And I always advise my clients to have their probiotics with a protein. If it can be whey protein, that's the best, because whey protein plus probiotics doubles the yield, doubles the biological value of the probiotics you're taking. And then there's a product called Florastore. So this probiotic supplement contains something called a bug, Saccharomyces boulardii, which has been studied for its potential to support gastrointestinal health. And there are antibodies that are usually positive in those with inflammatory bowel disease against Saccharomyces. By supplementing with Saccharomyces, that reduces inflammation and increases tissue repair in the intestinal tracts dramatically. Also, Florastore is particularly good for helping with diarrhea, which both Crohn's disease and ulcerative colitis usually are manifest. And then there's fiber-rich foods. So while high-fiber foods can be beneficial in some individuals with IBD, others may need to limit fiber intake during flare-ups to reduce digestive discomfort. So no two people are alike with inflammatory bowel diseases. And a particular individual may be different over time. Their needs may change. Sometimes they should have high fiber, as I mentioned, and other times it should be completely eliminated. So there is no particular specific diet. You'll find claims on the internet all about specific diets, but I'm telling you, and you'll find this out yourself if you don't know that already, which is probably why you're listening to this podcast, is that individuals just vary too much, and our nutritional needs over time change. So there's a dynamic changing of approach as the person's chemistries change, as the person's response to, let's say, foods and nutritional supplements are analyzed and determined and fundamentally personalized for each individual. And then there's B12 and iron. You need to know that individuals with IBD may be at risk of deficiencies in vitamin B12 and iron due to malabsorption or blood loss. So monitoring the levels of B12 and iron are important. So for example, if a person with IBD is not consuming meat products, they're almost certainly going to be deficient in B12 and iron. It's okay to be a vegetarian with these conditions, and in some instances, I actually prescribe that. But that vegetarian diet might need to have a composition of specific nutrients and supplements and foods that are, again, quite different from person to person. The best tests for iron are hemoglobin and hematocrit. When those are low, then a person's usually iron deficient. And if a person also has there's also something called total iron binding capacity and serum ferritin, and there are a few other tests which give us complete view of iron storage in the body, as well as is there a current iron anemia. And the iron doses have to be precise because giving too much can cause problems in and of itself. And as far as B12, you'll find, and I've certainly seen this over the years, that a person's blood levels of B12 sometimes are high. Most people will have high levels without even taking any extra B12, which leads me to think that the upper end of the lab B12 level is actually too low. Besides, here's what you need to know about B12. There's a serum and plasma test, and that's what doctors tend to do. They'll tell you that the serum level of B12 is high or the serum level of B12 is low. But the best test for B12 use in the body and need is the size of a red blood cell under a microscope. When the cell gets too large, that could mean that the person is B12 deficient, even if their blood level of the plasma is normal. It could be normal B12 in the plasma because it's not getting in the cell, so the cell is kind of saying, please notice me, it's getting larger. Large red blood cells are heavier, they're a strain on the heart. They tend to be associated with stickiness or coagulation or thickness of blood, okay? Deficiencies of iron can cause everything from fatigue to slow healing to brain fog, you name it. And B12 deficiency is also considered an anemia, which just means deficiency. And a person, as I mentioned, could be protein deficient, and that's also an anemia, vitamin C anemia. So there's over 14 different types of anemias. I had done a podcast on the anemias, which you can listen to by searching the anemias on my website at drmichaelwald.com. And then there's aloe vera. So some research shows that aloe vera may have anti-inflammatory effects, particularly if you combined aloe vera with something called deglycerinated licorice, or DGL, which is licorice where it's been deglycerinated with a glyceritic acid is removed because it can cause hypertension in some people or high blood pressure. But aloe vera may help to, along with glutamine and DGL, be very helpful for the bowel. Not for everyone, though. It's important to keep in mind that individual responses to these nutritional approaches definitely can vary. So you want to consult a qualified healthcare professional. And you need to also know that many supplements can adversely interact with certain medications that you might be taking. And then other nutrients and nutritional medication combinations might actually be positive. So I want to switch gears a little bit, and I want to talk about some additional interesting approaches to inflammatory bowel disease that are well outlined in the literature to be of use. The first one is the potential role of hyperbaric oxygen in inflammatory bowel diseases. So for those of you who are not familiar with hyperbaric oxygen, or HBOT, hyperbaric oxygen therapy, it involves breathing in either pure oxygen or pressurized air in a chamber. So that's known as a hyperbaric oxygen chamber. And there are several really important benefits that play a significant role potentially in the management of inflammatory bowel diseases. I wanted to review those with you because I found in some cases that this is the only thing that allows people to get over this inflammatory hump, because inflammation usually occurs in a poor oxygen environment. And as I'll reiterate in a moment, the benefits of hyperbaric oxygen have to do with the oxygen delivery under pressure, but also just the pressure itself. For example, about 10 years ago, I learned that nutrients in your blood or medications at the time you receive hyperbaric are pushed deeper into the tissues compared to if you didn't receive hyperbaric. So if you're going to take nutrients or medications, you might want to consider some hyperbaric oxygen treatment. So the one thing that's been proven to be, let's say, a characteristic of hyperbaric oxygen is its anti-inflammatory effects. HBOT, hyperbaric oxygen therapy, has been shown to reduce inflammation in the body, which is beneficial for individuals with any form of inflammatory bowel disease, which this anti-inflammatory effect will help alleviate, obviously, many of the symptoms such as abdominal pain, diarrhea, and rectal bleeding. These have all been studied. And then there's the tissue healing promotion of hyperbaric oxygen. So the increased oxygen levels delivered during HBOT promote tissue repair and wound healing, which can be beneficial for individuals with IBD who may experience damage to their intestinal lining. And that's not all. Hyperbaric oxygen has been shown to improve blood flow. So the enhancement and delivery of oxygen to tissues and organs is affected by hyperbaric oxygen. So this can aid in reducing ischemia, which is lack of blood flow to various areas of the intestinal tract. Because folks, in the intestinal tract, when there's inflammatory damage, there is usually reduction of oxygen delivery. And if that's happening, usually there's a reduction of nutrition as well. When you go into a hyperbaric oxygen chamber under pressure, blood vessels open up. They're thinking, wow, all this oxygen's around. I'm going to dilate my blood vessel to take more of this in. And this reduction of ischemia can promote healing in areas affected by IBD and its related inflammation. There are even antimicrobial effects, anti-infectious effects of hyperbaric oxygen. So HBOT has antimicrobial properties that can help combat infections, which are common complications in individuals with IBD. So there are so many potential benefits of hyperbaric oxygen. One other I should probably mention is the reduction of oxidative stress. So IBD is associated with increased oxidative stress. Think of oxidative stress as inflammation. And HBOT has been shown to reduce oxidative damage by increasing antioxidant capacity. Unbelievable. And what's even more unbelievable is that I have never, in my 31 years of doing this sort of work, met a gastroenterologist who has even once suggested to their clients with irritable bowel disease to receive hyperbaric oxygen therapy. So, as an adjunctive therapy, in other words, a therapy used in addition to other things, HBOT can complement medications and lifestyle modifications by addressing specific aspects of disease pathology like inflammation and oxidative stress. That's what HBOT does. And again, HBOT is hyperbaric oxygen therapy. And then there's the use of HBOT for management of various complications. Complications like fistulas and abscesses, delayed wound healing. These are classically improved with the use of HBOT in those with IBD. And then there's the promotion of overall healing. I know I'm repeating myself in some ways, but there's some nuances here. So by enhancing tissue oxygenation and promoting what's known as angiogenesis, which is the formation of new blood vessels. You want new blood vessels because, remember, in the gut of those with IBD, there's a lot of inflammation, blood circulation and oxygenation and nutrition delivery is cut down. So HBOT plays a crucial role in promoting healing and reducing the severity of inflammation in the intestines. And of course, all of this is going to improve the quality of life of an individual. The symptomatic relief provided by HBOT can contribute to an improved quality of life that can be dramatic for individuals with IBD, therefore allowing them to better manage their condition and engage in life. So what we've done today is we've reviewed several nutritional approaches to inflammatory bowel diseases. We talked about hyperbaric oxygen therapy because the amount of literature and study and scientific evidence for that is just overwhelming. There are hundreds of studies which can be found on the National Library of Medicine, which is pubmed.gov. We also briefly reviewed the basic approaches to the medical treatments. And I reiterated that the approach for each person with inflammatory bowel disease must be focused on figuring out what their unique biochemical needs are, how their bodies are particularly responding to IBD, and then making sure that all suggestions work well together synergistically, they do not interfere with one another, and in fact, they improve one another. Even the wrong nutritional supplement combinations or food nutrient combinations or even food combinations can be done wrong and can be disastrous if not balanced right for each person. So, thank you, everyone, for listening to this show entitled The Inflammatory Bowel Disease Disaster. My name is Dr. Michael Wald. You've been listening to Ask the Blood Detective. Please join me for the next show. And my contact information is info@blooddetective.com. That's my email. My phone number is 914-552-1442. And again, check out all the free content and even get the notes of this particular show or any other podcast that I've done over the llast year on the website at drmichaelwald.com. Take care, everyone.